So we actually think that not only exposure to gestational diabetes is important, but being born overweight is also important. In 1989, Dr. Barker was the first to hypothesize that fetal size had a repercussion for later development in children. And what he noted was that undernutrition in the womb, or what we call IUGR, was associated with an increased risk of adult obesity and metabolic syndrome. And this has been proven both in animal models as well as in epidemiologic studies. It appears that this Barker hypothesis is actually a U-shaped phenomenon, such that overfeeding in the womb, whether it be because of hyperglycemia or maternal obesity, seems to also increase the risk of adult metabolic complications such as metabolic syndrome. So one of the questions that often arises is, are children becoming obese because we're overfeeding them once they're born, or because they are fetally programmed to become obese? So a few years ago, the HAPO trial was performed, and this was an observational trial. And it was performed in an effort to examine the relationship between hyperglycemia, lower than that that is seen normally in diabetes or overt diabetes, and adverse pregnancy outcomes. And really the hope of the trial was to ascertain new thresholds for the diagnosis of gestational diabetes. But let me go through some of the findings because I think they're really important in educating us about the effects of hyperglycemia in pregnancy. This was a multinational study including 25,000 women. And what they did was they gave all these women in the trial a 75-gram 2-hour glucose challenge test at around 28 weeks of gestation. And then the providers were blinded to the outcome of these tests, and the patients received routine prenatal care. They did exclude anybody with fasting or overt hyperglycemia. Those women more than likely are either pre-diabetic or type 2 diabetics. And they looked at primary outcomes that mattered to us, which included neonatal outcomes. So as you recall, the diagnostic thresholds for GDM that are recommended by ACOG are based on a mother's future risk of developing type 2 diabetes. The HAPO trial was specifically designed to look at neonatal outcomes, not necessarily the maternal outcomes, although those were secondary outcomes. And so what they were interested in looking was looking at overweight fetuses or birth weight greater than 90th percentile, or what we call macrosomia, neonatal hypoglycemia, neonatal hyperinsulinemia as measured by an umbilical cord C-peptide at greater than the 90th percentile. Remember that C-peptide is a marker for fetal insulin secretion. The rate of primary C-section as well was considered as a primary outcome. The secondary outcomes are listed here and include neonatal fat mass, shoulder dystocia, the rate of preterm delivery, preeclampsia, and of course NICU admissions. And so this is what they found in their trial. What they found is, if you look at the y-axis is frequency, the x-axis is glucose categories, and if you look at the primary outcomes that they looked at, birth weight, primary C-section, clinical hypoglycemia for the neonate, and umbilical cord C-peptide at greater than the 90th percentile, suggesting fetal hyperinsulinemia, you see that with worsening hyperglycemia, there's a linear increase in all of these adverse outcomes. There was not one threshold or one area that we could pinpoint as being more concerning than another. It was a linear relationship. And then if you look specifically at each of the different values, so here, for example, again, you have frequency on the y-axis, and you have the fasting glucose level on the x-axis. And if you look at birth weight, umbilical cord C-peptide, you can see that there is a linear increase in all of these outcomes with worsening maternal hyperglycemia. And notice that these are lower thresholds than you would traditionally utilize to diagnose a mother with type 2 diabetes. The same was noted in the 1-hour value. Again, on the x-axis is the 1-hour value on the 75-gram 2-hour GTT, and again you see this nice linear relationship. The same was noted with the 2-hour plasma glucose. So again, what we're noticing is a trend with increasing hyperglycemia leading to adverse neonatal outcomes, specifically macrosomia as well as fetal hyperinsulinemia. So then the question is, can treatment of gestational diabetes reduce the rate of fetal obesity if we know that fetal obesity predisposes to then childhood obesity and potentially to adult onset of obesity? There have been 2 RCTs published to look at the effect of treating gestational diabetes on neonatal outcomes. The first one is the A-Choice trial, which was published in the New England Journal in 2005. Subjects underwent a 75-gram glucose challenge test, and they were diagnosed with GDM if the value was anywhere from 140 to 199, and that's what the World Health Organization recommended as being diagnostic for GDM at the time. Providers were then blinded to the diagnosis, and patients were randomized to either general obstetric care or, of course, care that we traditionally offer to women with gestational diabetes. And so here are the results of their trial. 510 women received routine care, and 490 women were randomized to the intervention group. And as you can see, there was a lower birth weight in the intervention group. There was also half the rate of LGA and macrosomia, and there was a lower rate of preeclampsia. And again, there was no difference in the rate of SGA among infants whose mothers were randomized to treatment. And this was very mild hyperglycemia because 20% of the intervention group required medication to obtain their adequate glucose control. The second trial was also published in the New England Journal of Medicine, and this was a multi-center randomized trial for the treatment of mild GDM that was performed here in the United States. And these women were diagnosed with GDM based on 2 abnormal values on a 3-hour GGT after they failed their 50-gram glucose load. But they did exclude women who had a fasting of above 95, again, because those women probably had prediabetes and they wanted to look at just mild hyperglycemia. And again, women were randomized to either routine obstetrical care or full diabetic care. And this is what they found. They found in the treatment group a lower birth weight, and then half the rate of macrosomia, and they define macrosomia as greater than 4,000 grams. Half the rate of LGA as well, noted here, and also they noted a lower fat mass distribution in women in the treatment group. And again, as in the previous trial, there was no difference in the rate of small for gestational age infants, and only 12% of the patients required pharmacotherapy in the treatment group to obtain adequate glycemic control. So treatment of GDM does appear to have a beneficial effect on birth weight and does lower the rate of macrosomia, which is what we're trying to avoid. So the model that we have currently in regards to the long-term effects of GDM on the neonate is that high maternal fuels leads to altered islet function in the fetus and predisposes to fetal macrosomia, which then later leads to childhood obesity, and of course adolescent obesity and impaired glucose tolerance, which then leads to impaired adult islet function, or what we call prediabetes or impaired glucose tolerance, whatever term you want to utilize, and then the development of GDM or pre-gestational diabetes, and so the cycle continues. Let me put in a little plug here for breastfeeding, because breastfeeding does appear to modify these risks, and we're going to be talking about that later at the end of our talk. So what are the long-term maternal effects? Because we've just talked about the neonatal effects of GDM. Let's move on now to talk about the maternal effects of gestational diabetes. Well, if you look at the risk factors for the development of GDM, again, they're very similar to those of type 2 diabetes. You can almost superimpose them on each other. If you're part of an ethnic minority, you're at higher risk of developing GDM. If you are older, obviously if you are obese, and if you have a family history of type 2 diabetes, you're at risk of developing GDM. But type 2 diabetes and GDM not only share similar risk factors, but they also are noted to have insulin resistance, which is something that we see in normal pregnancies, but is exacerbated in patients with gestational diabetes. So if you look at this nice study, and this is a table taken from Christian Resnick, our textbook on maternal-fetal medicine. If you look in the purple at the control group and in the blue at the GDM group, you can see here's the pre-gravid state. If you look at women with gestational diabetes, you see that the insulin sensitivity is decreased already pre-gravid, but it continues to decrease well into late in pregnancy. But if you compare that to controls, even though the insulin resistance in pregnancy does increase late in pregnancy and normal pregnancies, it is way more profound in those with gestational diabetes. GDM and type 2 diabetes also have many characteristics alike. These are just a few that I have highlighted here. Of course, we know about glucose intolerance, and we just discussed the peripheral insulin resistance that occurs with gestational diabetes, but there's also evidence that there's impaired regulation of hepatic glucose production as well as declining beta cell function in some of these patients. And again, there's ethnic varieties of this, such as, for example, you see more of a declining beta cell function in Asian populations as opposed to Latinos, who tend to have more of insulin resistance. But again, these are the classic things that you see both in type 2 diabetes and gestational diabetes. So they share many of the same features. But what do the studies tell us? Well, this was a nice longitudinal study that was performed in women who had gestational diabetes and compared them to controls. And they looked at these women and followed them for 11 years. So they did baseline studies and looked at them 11 years later. And they did follow them longitudinally. So they saw a development of these things as they went further. What they found was that there was a higher cholesterol, higher triglycerides, LDL, and of course a higher glucose, systolic blood pressure, and diastolic blood pressure in mothers who reported a history of gestational diabetes as compared to controls. Also, if you look at blood pressure, they saw a 40% increase in the systolic blood pressure over the 11-year time that these patients were followed in the gestational diabetes exposed mothers as opposed to the controls. And again, at each time point across a woman's lifespan, you see that the blood pressure is actually higher in those who had gestational diabetes. They also noted that about 13% of those who had gestational diabetes ended up developing type 2 diabetes versus 4.1% of controls, and about 27% of those with gestational diabetes developed metabolic syndrome as opposed to 8% of those in the control group.